Good afternoon or good morning, depending upon where you are. I'm Kimberly Westrich, the Director for Health Services Research for the National Pharmaceutical Council. Thank you for joining us today for our webinar on consumer-directed health plans, pharmacy benefits, and best practices. I'm also joined today by Laura Rutter and Chuck Reynolds from the Benfield Group. For those of you who are unfamiliar with the Benfield Group, they're a research, strategy, and communications consultancy that focuses on helping healthcare companies and employers improve healthcare value. Laura Rutter is a consultant with the Benfield Group, and she manages a range of research and communication projects. Chuck Reynolds is the president of the Benfield Group's employer practice. Chuck has nearly 30 years of experience in the area of health management, customer market research, and strategic communications. The topics that we'll be covering today include a background of our research project, the key findings on consumer-directed health plan strategies that employers are using, the key findings that are specific to the pharmacy benefits approach in their consumer-directed health plans, some information on employer perspectives on the performance of their CDHPs, and what we've identified as better practices in the world of CDHPs, and of course, some conclusions.
This is Chuck. I'm going to go ahead and start the presentation. So, greetings all. I want to go over the research objectives that we entered into this project with. We wanted to identify current landscape of consumer-directed health plans, or we'll say CDHP, throughout the presentation, and pharmacy benefits associated with those, to identify and describe CDHP and pharmacy benefits best practice approaches, and to establish the need for evidence about the total health and economic impact of best practice models and evidence about higher value approaches to CDHP pharmacy benefit design. The hypothesis that we were setting out to can be pictured in a diagram on this slide here. And when you look at the range that employers have in terms of designing their overall consumer-directed health plan approach overall, and also pharmacy benefits within that, you realize that employers can take what we call sort of a lowest total value approach or a best total value approach. And the lowest total value approach would be marked by essentially a Spartan benefit plan design where, I mean, you can imagine, and there are some employers who do this because of economic circumstance, they essentially provide employees with access to health benefits, but in a CDHP, but there's no contributions or very low contributions to any sort of HSA account. HRA contributions are very low. There's no drug coverage before the deductible is met, and there's not a lot done to support the employee in their decision making. And then on the other side of the spectrum, you'd have employers thoughtfully designing the deductible levels, the employee or employer contributions, perhaps having incentives so employees can get additional contributions into their HSA or their HRA account, where employers would be able to, or where they include prescription coverage before the deductible in both the HSA and the HRA. And the hypothesis was that those types of plans would get employers better health status of their employees, better drug adherence, increased productivity, decreased total human health and productivity costs, and overall improved employee satisfaction. That was sort of the basic hypothesis we went out with to test, and the way we were doing it was by surveying employers and talking with employers and other experts. So the way that we designed the study was we first conducted a survey, and the survey was, first of note is that we only surveyed employers who were currently offering a consumer-directed health plan. So if they answered that they didn't, they were screened out of the survey right away. If they did offer a consumer-directed health plan, they were let into the survey, and we had 96 employers complete the survey. We then went through a battery of questions regarding just overall consumer-directed health plan and health management strategy approach and the types of plans that they were offering, et cetera. And we looked at, we divided into HSA and HRA. We asked people to first indicate what was their most popular plan and their second most popular plan. And once we knew that, we would then drill down further into questions regarding their CDHP benefit design and their prescription benefit design within their most popular and the second most popular plan designs. Because a lot of employers will offer, several different plan designs for their employees. We wanted to just focus on the most popular plan designs and be able to get a good bit of information on those. Last thing I'll say is that if you look at this and you go, wow, these employers really had to be ready to answer a lot of questions if you saw the survey, and that is true. And actually, when we promoted the survey and we were sort of giving people the survey link, we said, look, don't click this link until you are sort of ready and you have information at your disposal regarding the specifics of your plan design. So just a few more just about who took the survey. I want to get through this fairly quickly. We can always go back and review this information if anybody needs it. But in terms of number of employers or employees, we had 16%, 1,000 to about 5,000 employees, 24% in that 5 to 10,000 employee range, and you can see the rest of the distribution with nearly 30% with 20,000 or more employees. The vast majority of employers, almost 9 in 10, had an average age in their workforce of 35 to 49 years old. And then we interviewed some stakeholders as well, and we'll see who those stakeholders were in the next slide, but we talked about their overall view of the consumer-directed health plan landscape, benefit design strategies, pharmacy benefit design strategies, what they're seeing in terms of outcomes for employers speaking for themselves. We interviewed other stakeholders as well in terms of their perspectives on employer satisfaction with various outcomes, measurement capabilities, future trends, best practices and things to avoid, helpful resources, and then gaps and opportunities in the CDHP benefit plan space. In terms of interview participants, you can see here we had a total of 24 interviews, and most of them were employers, but we also talked with employee benefit consultants, and these would be folks who were involved in pharmacy benefit design, advising, health plans, and other experts from EBRI, an organization called Incenta, University of Minnesota, and West Health. And then you can see the distribution by industry type in terms of the surveys. Most of them were manufacturing or transportation with some other, and you can see that distribution there. Basically, the point is that we had a wide range of employers, employer sizes represented in the survey. Now, I guess the last point is we have just a couple of slides in here that we've pulled from the research that we've done with a very similar sample of employers, and we did it because there were certain questions in the survey that we didn't feel we needed to ask about, say, consumer-directed health plan adoption and other things. We had that information, no need to ask it of the people we were talking to in this particular survey. So in our presentation, I'll point out a couple of slides where we're drawing on other research that we have just to provide context. We're going to now talk about overall CDHP strategy. And this first thing is there's this chart is from our research, and it's meant to show the growth in employer adoption of consumer-directed health plans. This is from our trends research that we've done since 2007. So we've got actually before that, 2006, I think was our first, maybe 5 actually, was our first research. But there's a period of time, 2009 through actually 2012, where the adoption of consumer-directed health plans was sort of frozen. That correlates with or coincides with the period of time when health care reform was passed, but there was a lot of uncertainty as to what actually was going to happen with it. And once going back to 2012, we had a Supreme Court decision. We had in addition to that, the election that year, the presidential election. So people are like, okay, it's settled. Healthcare ACA is law of the land. Now we can start implementing our strategies. So what you see here is since that point in time, since that confidence hit the marketplace, we've seen growth in consumer-directed health plans, and it's being driven to a great extent by the desire not only to share financial responsibility and to get people to sort of take accountable for their behavior changes and use of the healthcare system, but to keep costs down with the looming sort of excise tax as part of ACA. We consider sort of a limbo bar that employers have to get under from a healthcare cost perspective, and that's really driving a lot of this change, because CDHP, when you move to it, does certainly lower your costs. So CDHPs are growing, but also when you look at what employers are doing, they're also within their organizations encouraging people to enroll in them, because a lot of times an employer doesn't offer only a CDHP. They'll offer a consumer-directed health plan along with a standard PPO and sometimes even indemnity plans. But what that slide said was that there is that you have an increase in the number of, where you see 76% of employers are, so what we see here is that among the, when employers are offering CDHPs, we see most employers, 81%, are offering those plans to at least 75% of their employees. Okay, so that's point number one. Now we'll go to the next slide. And by the way, the only reason an employer wouldn't offer it to 100%, there are a couple of reasons. One is that you may have a union population where they're offering separate sort of benefits. And the other is sometimes companies acquire other companies, and within that acquired company mix, there's different benefit designs that are being offered. Now to this next point, in terms of increased adoption within the companies, we asked if 100% of your workforce is not eligible, how likely is it that employees who are not currently eligible to enroll in the CDHP will be offered that in the next couple of years? And we see that 32%, very likely, 27% at least somewhat likely. So 6 in 10 employers are saying they're going to be driving toward greater adoption of CDHPs. I'll also tell you that in our other research that we do, and other research you can find, being done by Mercer and other benefits consultants, employers are moving more and more toward full replacement. In other words, making CDHP the only type of health plan that their employee will be able to enroll in. Why that's important is because, a few years ago, when an employer would roll out a CDHP, they might leave it as an option, but it was really a benefit option for, as a choice for, generally speaking, that would be attractive to people who had a lot of income and free cash available to handle the deductible, but then they could also put money into their HSA account and use that as a retirement savings vehicle that's tax advantaged. And so it really, for a period of time, in many instances, it was a benefit very attractive to those who had money and who were reasonably healthy and didn't burn through the healthcare costs on a year-to-year basis. That's changing because employers are making it more attractive to enroll in a CDHP, or you could look at it the other way, less attractive to enroll in other plan options, and oftentimes more and more frequently also enrolling them or offering only a CDHP plan design. What that means is you have people who are low income and people who have sometimes multiple complex chronic conditions who are now enrolled in CDHPs, really not by their choice, but because that's really the only reasonable option that they have to get insurance through their employer. And that really does change the game when we start talking about things like benefit plan design and certainly pharmacy plan design. So keep that in mind as we go through the results. When we looked at, we asked here in the survey, remember we asked the highest enrollment, second highest enrollment, and what we see is that 67% of the highest enrollment plans are HSAs, and 71% of the second highest enrollment plans are HSAs. HRAs are less popular as the primary plan. If you go to the next slide, this is, again, data from our trends research, but we've seen, over since 2012, and it really, I'll tell you, before 2012, it was like a boxing match. It was like, HRA would be up one year, HSA would be up the next year, and it was kind of going back and forth. But then as of about 2012, we saw this decided trend away from HRAs and toward HSAs. And when we talked to, in our interviews, I just really remembered very clearly, one of the medical directors for a large health plan said, I cannot remember the last time I actually worked with a client that was starting in a health reimbursement arrangement type CDHP. It's just not done very much anymore. So that's an important thing to keep in mind as well, is that when we talk about consumer-directed health plans in terms of design and how employers are doing it right now, almost always you're going to be talking about health savings account-based plans. And the reasons for that, well, basically the HSA gets to deeper savings faster is really what it comes down to. And again, remember, the motivation for many employers getting into CDHPs now is to get under that excise tax level for 2018. And so that's really the major driver. Having said that, when you talk to experts and some employers who are using HRAs, they've gone with HRAs and are surprised that HRAs aren't getting more attention because HRAs leave the employer with so much more flexibility from a benefit design perspective, particularly pointedly when it comes to prescription benefit plan design. So another really important, and this kind of, I guess maybe took us by surprise a little bit, is that the consumer-directed health plan, when it's an employer, oftentimes, most frequently, you're going to be working with a benefits consultant, and they're like, okay, we want to add a CDHP to our benefit mix or add another one to our current mix. There's a sort of almost a standardized approach that has emerged that is sort of predictable now. And the reason is because it really isn't hard to design a consumer-directed health plan that meets the primary goals of employers these days. And those primary goals are to lower the costs, to bend that curve, the cost curve, or even oftentimes if it's an employer that doesn't have a CDHP and they go reasonably aggressively into a CDHP, either by incenting people into that plan or going full replacement, they will literally take costs out of their healthcare bill and go down. So that's an important goal. They want to engage employees. Well, all of a sudden you're rearranging who's paying for what and how things are getting paid for, even if at the end of the day most employees are really not paying more when you add everything in, premiums and deductibles and copays, et cetera. Even if employees aren't paying more, the way that the CDHP is organized, it gets employees' attention and gets them to focus. And then also provides this idea of the deductible where you can use deductibles and contributions into accounts, et cetera, for incentives. We'll get into that a little bit later. So it gets away to engagement. And then also mitigating force, or to mitigate workforce disruption. That's the third objective. So how much money can I save, and how much can I engage my employees without making people mad and having them walk out the door? So those are the three goals, and they're pretty easy to attain with a standardized approach. There's a lot of information now. EBCs have got sort of recipe books as how they can go in, help an employer decide, how to move what levers in the plan design to get to where they need to be, and hit this balance of cost savings, engagement, and minimal workforce disruption. And so there's essentially pretty easy to do, and when you look at how much control or influence, you might say, that EBCs, employee benefit consultants, have over the employers that they're guiding, if it's easy for them to do and they can replicate it, they make a lot of money. They're helping their client achieve these three objectives. Everybody's kind of happy. So what are the elements of the standardized approach? Well, the first one is to set up the basic CDHP design so it's sensitive to the employer. I mean, an employer that is in investment banking is going to have a different set of needs, clearly, than a retail operation, and that's going to be different than a manufacturing operation with a deep heritage of sort of paternalistic benefit plan design. So there is a lot of thinking that has to go into, okay, what's our fundamental strategy? How are we going to introduce it? Number two is cover preventive services, and that includes coverage of preventive drugs for an HSA. Number three is contributing enough to the employee's HSA or HRA account to minimize disruption. So we have a high deductible, but we can offset some of that deductible by putting in some cash from the company, so that at the end of the day, the net deductible to the employee, even if it's a $1,500 individual, if the company chips in $750, the person's on the hook for $750. So it's not as bad as a $1,500 deductible. Offering support, so tools and services that help employees practice good health habits and make good healthcare decisions. And then monitoring enough to identify worrisome trends. So the basic stuff are Are the emergency room visits going through the roof? Are we seeing hospitalizations going up? Very sort of baseline statistics, and then seeing if there's some adjustments that can be made. So that's the basic strategy and approach. But there are some innovations that are being adopted and throughout the marketplace, and they're important because when you look at opportunities to improve on the standard model, they become essential to addressing some of the issues that a basic model doesn't quite get to. So one is a mechanism to reduce what we call the net deductible. So it's the difference between the full deductible, either individual or family, and what the company is contributing. And many companies, 30% of the respondents, 40% with an HRA, 30% with the HSA, are tying incentives based on incentive-based contributions to the accounts tied to either taking a health screener, participating in various wellness programs, and a variety of things that you would maybe have as wellness incentives. The reward comes in terms of dollars contributed to the HSA or the HRA account. So somebody might have the opportunity to earn another $250, $300, $500, even $700 toward their HSA contribution, almost closing the difference between their deductible and what the company's contributing. So a lot of incentives being built in there. And then salary band based account contributions, only 11% of employers are doing this, but very interesting notion for employers that are concerned about the lower income employees who are now perhaps not having a good option to fund their, not having another option other than a CDHP. And if employees don't have cash flow, it may force them into some very difficult decisions about paying for things like doctor's visits and prescription drugs. So they increase the account contribution for the lower income employees. Over in the upper right-hand box, providing access to primary care and chronic disease management at a nominal out-of-pocket cost to employees, either through direct contracts with local providers or worksite clinics. We saw, we heard just one great example of an employer in Indiana, not a real large employer. All the employees were local, so that was an advantage for them. But they saw their employees, many of whom were relatively low income, having difficulty. Yes, ACA, you have to pay for the preventive visit, but what if you're diabetic and you have to have a visit every couple of months to check in, or some other disease that requires more regular visits? Every time you go in, there's a copay. There's a, you're eating through not only your deductible, but it's, it costs a lot of money. So what they did is they contracted directly with a provider and were able to basically arrange for those visits to be covered free of charge to the employees under a contracted arrangement. Very clever way to get around an important issue. On the lower left, we have front-loaded account contributions. Again, people who are low income, and sure, the deductibles may be $1,500 and the employer is going to contribute $500. I'm only on the hook for $1,000. But what if I've got a high-cost medication that costs me $1,000 a month, and all that's coming in the door for me from the employer is $1/12 of $500 in January? Now I'm on the hook for that minus the $1,000. Very difficult situation for people like that. So some companies have said, hey, we'll give you the full $5,000 in January. Yes, we're going to need it back if you leave the organization for any reason. We'll figure out how to do that, and they have figured out how to do that. But it's another way to protect people who don't have a lot of income. And then finally, enabling the HRA rollover, perhaps with limits. In other words, HRAs are not portable. People can't take the account with them when they leave the company, but there is an opportunity for employers to allow employees to accumulate funds in their HRA account, and this allows them to do that. And a lot of times employers will say, well, you can do it up to 20 grand, but then we're going to kind of shut off the tap there, and you'll have to, that's your max out. This is Laura.
All right. Well, thank you very much. We're going to shift away from looking at the overall strategy and really hone in on the pharmacy benefits approach. One big takeaway from the research was that pharmacy benefit issues really do play second fiddle to the medical issues when employers design CDHPs. And the reason for this is that a lot of the cost is on the medical side, and so quite often it drives the shift to CDHPs, and then it dominates the design process. We have 3 quotes here that really illustrate that. And the first sentence of the top quote really sums it up. And EBC told us, when we have conversations about CDHP design, pharmacy is employers' last consideration. We asked our respondents to categorize how strategic they were in their pharmacy benefits approach. And so what you see here is a 10-point question. On the lower end were the people who described themselves as not that strategic. Really, it was the medical issues they were paying attention to, and once those were decided, they paid attention to the pharmacy benefit issues. On the high end, we have people who say they were strategic throughout the entire process. So they considered medical and benefit almost equally. They used data to drive their decisions, approaches like that. And a big takeaway of this slide is that there's a large chunk of the marketplace that really is not that strategic in their approach. So you can see with the red box on the lower side, that's about 33% of our respondents who describe themselves as not that strategic. So you could call them passive or reactive or even tactical in their approach. We're about to focus in on the pharmacy benefit designs of the HSA enrollees, but before we do that, you need some background information. The way that these benefits are set up, quite often the enrollees in HSAs have to pay the full cost of medication until they hit their deductible. And then once they hit their deductible, they're able to go to lower out-of-pocket costs, so co-insurance or co-pays. That being said, there are some preventive drugs that can be covered before the deductible. Some of these are mandated by ACA, so that would be immunizations. But the Treasury Department has issued some guidelines on other preventive drugs that can be covered before the deductible. So according to the Treasury Department, these preventive drugs are ones that are either for a condition that a patient has a risk for, but the condition hasn't manifested itself yet, or the individual has recovered from a disease and they're taking drugs to prevent that disease from occurring again, or the drugs are taken as part of a preventive care program. So even though there's some guidelines, they're not exactly explicit, and there is some confusion about what exactly the IRS considers a preventive drug and what it doesn't. And this is important because these employers could incur some tax penalties if they overstep the guidelines. So with that as background information, we asked our respondents how many of them covered preventive drugs apart from the deductible. And again, these are the HSA respondents. And you can see that 56% said that they did cover some of these drugs. And I'd really like to call out the text box here at the bottom of the slide. During our interviews, we found from the employee benefit consultants that this approach of covering some preventive drugs is really part of that standard approach that Chuck talked about. And we expect the number to be quite a bit higher, even now since we did the research last year, and even more as CDHPs become more popular in the coming years. We asked our respondents who covered preventive drugs apart from the deductible just which types of drugs they covered. And you can see that it really focuses on 6 therapeutic areas. About half of our respondents covered these drugs. And it's no surprise to see that these are the types of diseases that are often in the news because they're common, they're high cost, and they're chronic conditions. I'm going to pause here for just a few seconds to let you take in this because in addition to diabetes and hypertension and the diseases that you would expect to see on this list, there's quite a bit of information below the line. Now, there's no set approach to how employers cover the preventive drugs apart from the deductible. You can see that just over a third cover all the drugs in a class, whereas the same percentage, 36%, also cover generic and preferred brands. And then there's 22% that cover generics only. We asked the respondents what factors were driving their decisions when they decided which drugs to cover and which drugs to not. And it's telling here that the most important factor was the recommendations of their health benefits advisors. So that would be their PBM, their health plan, or their consultant. 77% of the respondents in this section rated those recommendations as moderately or extremely important. There are some secondary issues of importance, like controlling costs and not overstepping those guidelines from the Treasury Department. but by far and away, it was the recommendations of the advisors that really drove the decisions. Now, we had a percentage of respondents who don't cover any drugs before the deductible, and we asked them the same question: what were their decision factors? And here you see that it's much more balanced, and the most important decision factor was not wanting to overstep these Treasury guidelines. But almost equally important were those recommendations from the health benefit advisors, as well as the recommendations from the tax and legal advisors. They're neck and neck. And I'd like to hone in on these Treasury guidelines because we expected them to be more of a concern, and it does show up in here in the survey results that they are on employers' minds. But this is where the interviews come in, because they really showed that the lack of clarity around the guidelines and the fear of stepping over them are not really keeping any employers up at night. The issue is something of a hot potato, and that is because it is confusing and there is not explicit clarity. So what we found is that a lot of times employers and their advisors really outsource these decisions about which drugs should be on the list to their PBMs. And that's both a form of protection the employers feel like, that they have the experts taking care of it, but it also puts the PBM in the driver's seat, and that the employers and their advisors are taking a more passive approach. All right, now that concluded our HSA section, we're going to focus in on the HRAs, and they are not subject to the same guidelines that the HSAs are. What you see most often in our research was that the HRA pharmacy benefit designs really mirror what you would see with a PPO. So in this case, 56% of the HRA respondents enrolled or had their employees who were in a CDHP covered by a prescription benefit card plan. So they would pay a copay or a co-insurance apart from the deductible for their drugs. But there's a significant portion as well that require their enrollees to use money from the HRA until they meet the deductible. And then once that occurs, they're going to roll over into a prescription benefit card plan. Now, value-based insurance design is something that's been in the news quite frequently in the past several years. And you could explain it as an approach that employers take when they would like to encourage their employees to be adherent with their drugs and really keep up with their medications, especially for those conditions that are going to be very expensive if the employees don't take their medications as prescribed. And so what an employer might do is offer some of these drugs at no or a very low copay with the hope that that's one less barrier for the employee and that they're more likely to take their drugs and prevent these catastrophic events or high costs that might happen if they don't take the drugs. So what we found is that 3 in 10 of our respondents take a value-based approach, and it's no surprise to see that it's those common, chronic, and expensive conditions that are most frequently covered. So in addition to asthma and diabetes, there's also hypertension and cardiovascular disease that were fairly common. We're going to turn it back to Chuck.
All right, thank you, Laura. Before I move on, I want to just mention, if you haven't seen it, it's worthwhile going to the Center for Value-Based Insurance Design, Mark Fendrick's group at the University of Michigan. Mark and his team put together a really nice white paper on this whole issue of preventive drug lists, what's on it, and clarifying the guidance coming out of Treasury. It is a really well-done document, and in a way, it's a call to action to try to drive a better clarity in this area. And basically, what Mark is suggesting is that the definition of preventive drug be clearly defined to include secondary prevention, because under the current law, if you interpret it strictly, you could conclude that giving somebody who is a diabetic anti-diabetic medicine is subjecting you to risk in terms of tax implications because they already have diabetes. You're not preventing diabetes. You can argue, well, I'm preventing secondary impacts of diabetes, kidney disease, and blindness and amputations, all that stuff, but that is not currently the way the law is written. And so that's part of the thing that's creating some hesitancy, if you will, in different employers and benefit consultants, et cetera. Great paper. Value-Based Insurance, Center for Value-Based Insurance Design white paper on preventive. I forget what the title is. If you need, just contact the folks at NPC. I'm sure they'll be happy to send you a link to the article. So first thing I think, this is we asked employers to indicate the degree to which their company was experiencing these beneficial outcomes. So the reasons that employers that might get into offer CDHP, the benefits they'd expect to receive from that might include things like increased generic drug usage, increased preventive care service utilization, lower medical costs, lower prescription drug costs, increased engagement with healthcare decision support information and tools, and perhaps even providing an attractive new benefit option for their employees. And what we see here is that most of these are being, these benefits, positive outcomes, are being experienced by employers either quite a bit to very much or moderately, and only few employers are seeing them very little or not at all. And this even actually includes the bottom providing an attractive new benefit option for their employees. So remember what we talked about earlier, the reasons why employers are getting into CDHPs and they're moving forward, the major outcomes that they want: lower costs, without a lot of employee pushback, and the ability to engage employees. Generally speaking, you'd say they're getting those outcomes, so they're pretty happy. And also now recall the diagram I started off with, the hypothesis. Because employers are seeing these basic outcomes, they're perceiving them, and many of these employers really don't have much more data than sort of the reports that they get from their health plans or that their EDCs might prepare for them at a pretty high level. All employers that we surveyed, not all employers, most of the employers we surveyed, regardless of how strategic they were, are pretty happy with what they're getting out of their CDHP strategy at this point in time. The one comment I will make with respect to, and we're beginning to see, if you watch the news media and what's happening as the economy heats up a little bit, I think Mercer just yesterday, if you get their little news feed, they were talking about a specific industry, the oil and gas industry, and the shortage of talent and employees who can help drive these businesses forward at this point in time. We're beginning to see the labor market heat up. And so this idea that you can sort of move your benefit programs around however you like and nobody's going to squawk too hard about it, well, for the last, since 2008, employees have kind of kept their heads down. Now that the tables are turning a little bit in terms of market leverage for human capital, you might see a little more reluctance on the part of employers to do things with a benefit plan design that employees might not be too happy about. So it's just it's a factor that we thought about as we did this research. Here the question was similar. We asked, indicate the degree to which your company is experiencing each undesirable outcome. So some of the things that, if you do the literature review and consumer-directed health plans, some of the criticisms of those plans are the items listed on the left, and we were asking employers whether they had seen these outcomes, these negative outcomes in their data. And what we see is, by and large, there's not a lot. Employers are not reporting a lot of negative outcomes. You don't see a lot of deep purple on this slide. Having said that, we've highlighted a few of the items here. More than 50% of employers are at least moderately observing or experiencing lower income employees being hard hit by costs. Again, more than 50% seeing patients with serious chronic conditions hard hit by out-of-pocket costs. Nearly 50% seeing that patients who are less likely to seek needed medical care, and 36% patients less likely to purchase and take medications as prescribed. So there's some, at least, and when we talk to employers about this, unfortunately, most employers just do not have the data to be able to pinpoint these suspicions that they have, but they probably get it from hearing employees and anecdotal and complaints that come in, but they're not huge, because what you have to have is an intersect really here of an employee that doesn't have a lot of money, has a lot of chronic conditions, is in a CDHP where they feel like they're not being supported well enough, and perhaps their health is in jeopardy because they can't really afford the treatments that they need. But that's a concern there. The other comment that sticks out in my mind is one of the health plan medical directors we interviewed who basically said, look, I suspect we have a problem where you find people who have little money and a lot of healthcare problems. He goes, but I haven't seen the data on that. Very interesting comment. I want to talk now quickly about CDHP better practices. So this is where a bit of art and science came in. We stepped back, we looked at all the results, we looked at the interviews, we looked at the data that we had, and we tried to identify some better practices. And our assessment of better practices are those that address concerns about potential negative impacts of the standard practices, particularly on low-income and or chronically ill employees, and also practices that are likely to positively impact employee and family health, productivity, or satisfaction. We found that best practice practitioners often have a broader perspective on the outcomes desired from their benefit strategy. They were looking more at a population total health and the access to healthcare services, productivity, employee satisfaction, as well as costs. And while these best practices may also reduce costs in the short and long term, cost savings was not their only consideration. So I'm going to show you a scale next where we're looking at the importance of the best practice and the sort of what we consider to be the gap. You know, what is the rarity, if you will, of the best practice in the marketplace. So this slide, the left-hand vertical axis has the importance, and then across the bottom you've got the gap in practice. And so if we focus on the upper right-hand quadrant, these are sort of the most important practices that are they're hardest to find, if you will, when you look at the information and you talk to the experts. And they include the following 5 items. One is engage in determining your HSA preventive drug list. And the idea here is to make sure, particularly was voiced by some of the folks we talked to, that if employers and their consultants don't just sort of hand off the assignment of what's on that list and say, look, I can't really touch it because it might create a tax problem for me. If they don't do anything more than that, they're leaving themselves potentially open to gaps in sort of preventive drug coverage or people having access to the drugs that they need. So it's important to at least study the list, consider it carefully against sort of the health goals in the population that you have, et cetera. Number 2, front-loading account contributions. Not a lot of employers doing that. Again, where there are sort of low-income, high-need employees, they're going to be in a pickle early in the year, particularly. Using salary-based account contributions, if you remember, only 11% doing that. Using data sounds simple, but from the planning stages through the evaluation and seeing if these programs are working, we're not seeing as much data used, but that's a constant problem, I think, with many employers and their advisors. And then implementing value-based pharmacy benefits within the HRA, but also it's possible to do that within HSA, right? I mean, you have preventive drugs, you can design how those drugs are covered, but again, it requires going back to number 1, which is engaging in that preventive drug list and thinking about what's on there. You can see the other items on this list. We go to the left, we see things that are moderate in practice, but still high importance, having a data-driven strategy, covering a broad list of preventive drugs and plans, which is becoming basically, I'm not sure, I don't think Laura said this, but basically the way it works is the EBC says, well, there's 3 PBMs that we're considering. Here's the information on them. You're doing HSAs. We recommend covering preventive drugs. Here are the preventive lists for each of these PBMs, and they're not the same lists. They're compare and contrast. So here's the kind of the skinny list for example, Caremark, and here's the more generous list, if you will, for Caremark, the more comprehensive list. And the employer is basically just sort of picking the list with the guidance of their EBC. But there's nothing other than comparing what might cost me more or less. There's no getting into the list and shuffling the deck and saying, well, put this in, take that out. Deductible levels and keeping what we call that net deductible in a reasonable range to minimize the pain is a high importance, but moderate in practice. And then having HRA enrollees covered by a prescription benefit card plan, you saw 56% are doing it, but 44% are not, which is probably not the wisest way to go. So we'll stop there. In terms of this particular slide, you'll have time to look at that. And we're going to summarize with just a few conclusions here. This tells a bit of a story, so stay with me. So first of all, more and more people, including those with chronic high-cost conditions and little income, are enrolling in CDHPs, and not always by choice. Number two, a standard approach has emerged, and it's helping most employers achieve those key goals that we talked about in terms of cost containment, employee satisfaction, and engagement. Third of all, many employers are at least moderately concerned that their sicker and lower income employees may be harmed, but most employers and their vendors or advisors lack the data that they need to see the impact on those subsets. As such, while the hypothesis that a strategic approach provides better outcomes can still be inferred, and I'd say our results lean that direction, but it's not enough to put it in a quantitative way at all. Our research is inconclusive. Some employers are leading the way with strategic and innovative approaches that address the concerns about employees with costly chronic conditions and the high need for medical care and prescription drugs. And for patients, the good news is that the standard approach has emerged and does include preventive drugs. However, due in large part to this perceived tax risk, employers are being advised to just choose among PBM lists and not really to mess with them. So some would argue that the PBMs need more and not less employer or advisor input and oversight when it comes to what gets included or excluded from these drug lists.
So for those of you who are interested in the publication that Chuck mentioned that Mark Fendrick Center put together, it's entitled HSA-Eligible High Deductible Health Plans, Updating the Definition of Prevention, and we did push the link out to webinar participants, and if anyone had trouble accessing it, please let us know after the webinar. We'll be happy to get it to you. I'd like to actually start with a question that's related to preventive coverage and the issues Chuck was just talking about. So the employers clearly indicated to us that they're relying on their PBMs and their advisors to determine which drugs are considered preventive. And we're seeing these trends in the PBM market of moving towards narrow coverage, and sometimes it's happening in a fairly aggressive manner. So these two trends coupled together, that employers are relying on PBM recommendations and PBMs are increasingly moving towards narrow coverage, seem to set up an environment where employees may begin to have difficulty accessing the medications they need, and it could compromise clinical and productivity outcomes. Is this something that we should be worried about?
Yeah, I think it's a really good question, and I think it's like very much when you're trying to design plans and design, there are a lot of people who will do just fine with the way things would be. Either have the cash, they can afford their own option. I know a medical director for a major company, his company doesn't cover the cholesterol-lowering medication that he needs. He has the ones that are covered. He has side effects, muscle weakness, and other things, so he has to take something that isn't on the list that he can afford to pay it, right? So for a lot of people it's going to work, but not everybody is going to fit into that general box. And while the sort of almost one-size-fits-all approach works for many, it doesn't work for all. And I think that's one of the things that this research pointed out is that leaves a vulnerability. And to the extent that employers have been scared away from even having a conversation about what's on the list, I think it sets up a very dangerous situation where there's going to be very little push. I don't care what market it is, to be honest with you. You could take a look at any business-to-business interaction. When the customer stops talking to the supplier in a sort of critical way about what they're buying, it's not good. Because the supplier can, I'll use the word, I don't mean anything bad, but the supplier can kind of get away with whatever they want at that point in time. Now, you're relying on the supplier to be sort of good and honest and to deal with whatever it is. I can consulting, auto parts, it doesn't matter. But it's better when you have a relationship where the employer is engaged with the supplier in any supply chain, and this is no exception. And it does bother me that employers are saying, look, this is a part of the supply chain we're not talking about when we're talking about prescription drugs that are really the major tool used to manage diseases and conditions for people who have illnesses. So, longer answer than you maybe wanted, but I get a little worked up about it.
Thank you, Chuck. So, one of employers' primary stated goals is to engage their employees. And if you look at the consumer-directed health plan's kind of standard design, we are seeing that it's primarily engaging employees on being cost-conscious, which is, of course, an important issue to engage on. Are there examples of designs that really focus on engaging employees on achieving better clinical and productivity outcomes? Is there a way that we can focus on making sure that quality isn't lost in the quest for cost containment?
Laura, do you have anything to respond on that with? I do, but I don't want to
myself off mute here.
Monopolize.
So, Kimberly, we were talking about the engaged employees, correct?
Yes.
Okay. So I think one of the good examples is one that Chuck mentioned earlier, where the employer saw a weakness in the preventive care. And they have over 1,000 employees. They qualified for our research. But they also were able to be innovative and adopt their benefit design so that the preventive care was covered. So, yes, there are examples, but it's not necessarily coming across in that one-size-fits-all approach that Chuck talked about earlier. They're really more bright spots. And I would also add into that a lot of it can be done, too, which was only tangential to our research in this case, but some of the support systems that the employers might have in place. So if they have, for instance, really good education about these cost and quality tools, which are lacking in all the information that employers need right now, or if they provide really robust and popular health and wellness programs, that can also really help engage employees and help them achieve that sweet spot of CDHPs that they're going for, which is the engaged and health-conscious employee.
Thank you. So we have one final question for today. The employers indicated that they had some concern about their most vulnerable employees, the ones that had lower incomes and or serious chronic conditions. They also indicated that they didn't really have the data to be looking at their outcomes. What type of follow-on research would you recommend to look at the impact of consumer-directed health plans on these employees in terms of their access to medications and their clinical and productivity outcomes?
I think the first place I would look is maybe some of the data integrators, aggregators who have information that includes not only health data, but information about employee salaries, and then has data about companies that have had a variety of consumer-directed health plan approaches in place, and be able to look at the data to see the impact on various employees under various benefit plan design options. Difficult research to do because there's so many levers to pull and impacts that you can have in terms of the deductibles, contribution to deductibles, a variety of other things. But that research really should be done because I think it really has implications for how employers design these plans. Again, if the trend is toward greater adoption and deeper penetration into the workforces where the low-income and sick employees are going, that has implications. And also when we look at what's happening when companies move over to private exchanges and employees are buying down into benefits, that's a very attractive thing to do because I can go from a premium for a family of four maybe of $450 down to perhaps $220. I'm saving that $230 a month. I'm probably, maybe I'm not putting that into my savings account. I'm not applying it to healthcare expenses anymore, and then something happens. Somebody comes in with a disease in my family, or I have a medical need, and I don't have the money to pay for it. There's a lot of education needed, so I think the implications of these plan designs need to be made available to employers as well as to employees so they make better choices.
Thank you, Chuck and Laura, so much for joining us today and sharing the results of your research with us. And thank you to everyone who participated in the webinar. Thank you so much.